2024 meeting of Kittitas County Public Hospital District 1. Board of Commissioners regular meeting to order. Andy, on top of the attendance, do you need a roll call or anything? Okay, thank you. So the agenda, there's one small addition under new business. We're going to, Eric is going to mention something about Habitat for Humanity, so I've added that to the agenda. Any other changes to the agenda? Do I have a motion to approve the agenda as amended?
So moved.
Second. Motion from Erica, second from John. All those in favor, please say aye.
Aye.
Aye. Unanimous. Thank you, Bob. All right, so we have the consent agenda. It has the minutes from our December meeting that was held on January 4th. Checks, Foundation Report, Finance Committee minutes. Anything people need to talk about in there, or you want, or you're ready to approve it? So if anyone's ready to approve it, we can. I'll entertain a motion.
So moved.
Okay. Okay, Erica makes motion. Bob seconds. All those in favor of approving the consent agenda, please say aye.
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 All right, thanks, Bob. All right, so now it's time for public comments and announcements. Remember, if you have a public comment or announcement, please state your name and where you're from, and try to keep it to about 3 minutes. And remember that the board does not respond to public comments in the moment at the meeting. Is there anybody who would like to make a public comment or announcement? Yes.
Hi. My name is Joan Bennett, and I'm a certified phlebotomist and lab tech. And I worked here for 15 years on the night shift, starting in 2006 under the administration of Eric Jensen. Then came Paul Nurk, and now we have Julie Peterson. Here in my hands is this book on risk management for healthcare organizations. I pulled this out of the trash during the pandemic in 2020. It's copyright dated 2004, so I'm sure it's a lot heavier now, or all online. But anyway, I wanted to thank the BOC for your dedication to KBH and for listening. I sometimes wonder if you're understanding what I'm trying to tell you. And so last night I went to a public meeting and Dr. Larson was there. He was talking about trust in the community and building trust in healthcare. And I took that to heart because here at KH, from my standpoint of view, trust is seriously lacking. There's a good reason for that. And I have asked for an opportunity to speak with you all directly with feedback. And for that reason, I asked the League of Women Voters if they would arrange a meeting with our elected officials. And I just wanted you to know about that. Thank you.
All right. Thank you very much, Joe. Any other comments or announcements? All right. In that case, we'll move on to a presentation. Tonight, we're going to have a presentation from Stacey Alea, who's going to come back on the phone update. Stacey.
Actually, Angela was going to present. Could we either do that with my operations report, or do you want me to go ahead? I can present it, and then if you have questions, Angela can answer them when she comes in.
That's all right. If someone else is gonna help you out, we can wait.
Okay,
That's fine.
thank you.
If there are no objections from the other board members, we'll just move this down to our operations report. Is that all right?
Thank you.
Yeah, sure. No problem. Stacey. Okay, so first up then we have quality with Mandy Olson. Mandy?
So you have my report in the packet there. So I just want to start by commenting on the DOH CMS Centala investigation and just let you know that we are working very closely with Julie Martin, Dee Dee, Rhonda, the director, Kimmy in ultrasound, Dr. Schmelzer, been working all week, but working very hard to make sure that we're drafting a plan of correction that's going to be, it's going to be accepted. And then when we're resurveyed, we'll have no findings. So that, that is due on the 29th, which is Monday, but we're hoping to have that submitted by tomorrow. I don't know if you have any questions about that. Anyone else wants to comment on that?
You want to just quickly summarize what the finding was that we're trying to overcome?
So they are saying that we need to have a complete medical screening exam prior to a patient being discharged from the emergency department. And in 3 cases, they said the patient needed to have an ultrasound prior to being discharged. Or that there wasn't sufficient documentation to show that a complete medical screening exam was done. In all of those cases, we felt that a complete medical screening exam was done. And that an ultrasound is not always necessary in those cases. But we're going to do what we need to do in our practice and in our plan of correction to make sure that that's not a finding again.
Thank you.
In all 3 cases, the patient received definitive treatment before leaving the emergency department.
Well, I appreciate all the work you guys have been doing on this. I know it's been taking a lot of your time and effort, so thanks a lot.
And then I really don't have any additional comments unless any questions that you might have.
Are there any questions about Mandy's report? We also have the dashboard here. Anything you want to call our attention to on the dashboard?
Really great things. Not really.
You call attention to a couple of things in your reports. Anything that you guys noticed that you'd like Andy to sort of extrapolate on, or anything you that wasn't mentioned in the report you saw on the dashboard?
I was wondering what these ladies are investigating out here in the construction site.
Well, you may not realize, I didn't know it until infection control is part of quality, but in any construction in the organization, they have to have infection control review their plan for maintaining the safety of our patients during construction. So that's part of that team. They get their own part of that. So they have to go around and they meet with Ron routinely to do, I can't remember ICRA's, what is it stand for? Infection control.
Risk assessment.
Risk assessment has to be done on every project.
Yeah. Once we get to rounding, it's infection control risk mitigation.
That's such a broad and important scope that they have. I didn't realize it went that far. How cool is that?
And they really enjoy the partnership they have with Ron and the team to get those done.
Yeah, it's been good.
Yeah. I like that picture. It wasn't their favorite picture of themselves, but
Oh, I think it's a great picture.
Hard hats are always a good one.
Other questions for Mandy?
I was gonna say, it's nice to see Linda still involved there, joining the Kittitas County Board of Health. And is that a willing thing on her part? They recruit her, or?
yeah, a little bit. I think there's a position open previously and we thought about her, but it was a little too late. And so we were fortunate that she did. And I even, you know, she's not my employee anymore, but I just can't help brag about her. I think that's a great thing for our community.
Definitely. Anything else? Thanks a lot, Mandy. All right, next up, we have the CEO report from Joey Peters.
Yeah, I would just call out the weather continues to be a challenge and pile on. In addition to that, in terms of staffing, we have a number of folks that are out with COVID and kids had COVID. And so just continuing to cycle through that. The Attorney General did acknowledge the receipt of our letter, ours and 27 other public hospital districts who were required to respond by January 15th. So all they did was acknowledge that they had received it timely. I had an opportunity to sit through civil treatment training that Amanda Scott had organized, and I just found it to be very useful. We had a consultant come in who worked with the physician leaders, with leaders from the organization and with specific departments, and it was, from my perspective, great training and a good refresher. So I know Amanda's doing a lot of work in that area. And we did have a great time saying goodbye to Andy Schock, and I haven't seen him since, so he's one of those that retirement may actually take with. So Karen probably doesn't know that part. Yeah. And just really proud and excited about the new services that they're offering at pediatrics with case management and helping coordinate services for our pediatric patients. And again, that grant applies not just to patients at pediatrics, but pediatric patients throughout the system. So I know that's a resource that our pediatricians needed and wanted, and it's great to be able to collaborate. And we thank Mitchell for finding the money to do that. I'm happy to answer a question.
Any questions about the CEO reports?
Bummer about pipes.
I know.
So do you think that letter from the equivalent abortion services, do you think that was just basically to inform everybody to do this, that it wasn't actually any kind of threat or anything like that, that it was really was just?
The reproductive privacy
Right.
act.
Yeah.
I hesitate to try to get in the head of the Attorney General's staff, but I think they have real concerns. They have concerns with access. And I think it also probably, there's a component of it that goes with the border hospitals with Idaho, making sure that everyone who needs access is receiving access. I think they're also, the AG is on a learning curve about what termination services look like in 2024 relative to 2014 or 13 when they last approached this with a couple of public hospital districts. So again, I am confident. I know Stacy and Dr. Martin and the other Stacy are working on scripting and making sure that we are compliant and that we're clear that what we're doing is complying with the Washington Reproductive Privacy Act.
Okay.
I also know that one of our rural hospitals received the same letter despite the fact they have no birthing center. They do have providers that prescribe birth control and give prenatal care. But at 36 weeks, care is transferred to another facility. So they're really struggling to figure out.
Any other questions for Julie about the CEO report? Thank you, Julie. I see we have Amanda online there. Hopefully everybody's had a chance to review numbers in her report here. And is there anything you want to call our attention to?
Yes, hello. I apologize. I'm one of those individuals that is homesick, so I am remote, but
You don't have to apologize for being sick. It's
thank
okay.
you. Yeah, so I do just want to say thank you, Julie, for the shout out for civil treatment class. I'll spotlight that more about that program in the next board report. And I also just wanted to point out, we do have some year-end numbers in my report. So Kyle did a really good job of talking about the growth in our student and volunteers program that he's been really working on. And then you might have also noticed that we did have a little uptick in turnover. And so I did dive into that a little bit. And as you know, I've been really working on increasing our exit interviews over the past couple of years. So I plan to do more of an analysis on that. But one thing that did stick out to me is the way that we are working on making sure our per diems are at an accurate status. And so 30% of the turnover that's actually in that number on my report for 2023, which is 25.25%, is actually per diem. So about 28% is actually per diem. And John had a great idea a few board meetings ago to track those per diem numbers in my numbers of employee count as well. So you can see that is a big part of our population. So anyway, that's just one piece of that. But as always, we look at more feedback from our employees in exit interviews around compensation, relocation, culture, those types of things. And if there's anything the board has questions on or would like me to expand on in the future, I'd be happy to answer questions or include that in my next report.
Any questions for Amanda about the numbers or the report?
Not a question, but just a comment, your count for hirings for 2023, 206, that's so impressive. How does that, do you know how that compares to prior years?
It's definitely increasing. It feels really good. And it felt really good because Rhonda, before she transitioned from our recruiter role, she's now in surgery with us as a surgery coordinator, which is great. So she's still with us. And we hired Heather Kerwan from the clinics for our recruiter position. So that's in my report as well. But before Rhonda left, she said, I just want to get to 200 employees before I left. And she got to meet her goal. So she was so excited for that. So she did incredible work, and it's been a very productive and busy year in HR.
I just, going back to the turnover rate, one of the disciplines that Amanda has brought to us, our per diems are required to make themselves available for a set number of shifts over a period of time. And we used to just add and add and add to that list. And she's done a really good job of making sure the directors, if people truly aren't available to work, that we're taking them off the per diem list. So we have a more current, I think, shorter list of per diems, and it's a little less work to call through and come through. So.
Any questions for Amanda?
I have a question.
I'm sorry, it's not public comment time right now, but if you'd like to relay this to the board, maybe after the board meeting, we can.
Okay.
John?
So I had a couple of questions. So Amanda, first of all, in per diem, does that include like locums and people such as that, or is it a different category?
No, it's a different category. So locums and travelers are through agencies, so they're not employed with us at all. So you don't see them on my metrics, but Jason does a really good job of tracking that in purchased services and temporary labor. The per diems are really people that are meant to be kind of more on-call, mutual agreement, filling in for shifts when there's vacations, sick calls, or other needs, which has been very, very helpful. I think the challenge is, though, they don't have a regular schedule, and so they might not always be available when the manager calls them. And so there really is this kind of mutual agreement, that has to be made when they're working. So we have some really great people that really help us out in times of crisis. And if they're not available, we just want to make sure that we're planning ahead with them of what works for them, what meets our needs, and how we can keep them at the appropriate status. Jason and I also have been having recent conversations too, because in the opposite, if they're not working, we want to make sure that they're not listed as active. But if they are working a lot, sometimes we have that issue where they're working more than expected. We need to make sure that we have them at the appropriate FTE status for budgeting purposes, but also for their own benefits and accruals for time off and that kind of thing. So it's kind of a tricky area, and one that is a unique population, I would say.
Thank you, very helpful.
Yeah.
Second question, does your department oversee this high school event that takes place in July?
Yes, yeah, and in combination with community relations, we partner on that. Michelle's team and all the directors that help out with job shadows and things. But Kyle has done a good job with that. And he's also had a lot of mini events, I would say one-day events with other local high schools that have gone extremely well to highlight our apprenticeships and career development. And this is just something he's really passionate about and has really brought, I think, with him in his role. He's doing a really good job with that.
So, because I have two high school age kids, and in talking to some of their friends about this opportunity, I realized I don't really understand what opportunities they're given during this week-long thing that they're applying for. Is there a place I can get more information, have a better understanding of what it is we're pitching to them? What sort of things they would be doing? What would a typical day during that week look like, sort of thing?
Absolutely. We have some flyers and things to go out as well. And I think we're still working on our agenda, but we can talk to you about past years, what we've done. And we usually coordinate directly with the school contacts, so with the school counselors for that. But we do open it up to other community members as well. So we'll get you some more information on that, John. I'd be happy to reach out to you.
Thank you.
You're welcome.
Any other questions for Amanda? Thanks a lot, Amanda.
Thank you.
All right. Then we have Ron Erlacher, who's going to update us on the expansion projects. Ron?
All right, that starts on page 22. And some updates from there. They got the roof is completed, short of a couple little details, but we are in the dry in that expansion area, so that's good. They've got the internal framing complete this week. They just finished that up. They're now moving to mechanical and electrical rough-in, starting from the west side and working around this way. So that's all underway. And the energy project, now that the penthouse is done, they're doing prep work for that, getting all that ductwork installed. And that'll be in full swing on Monday after the penthouse is painted out. So there's been lots of coordination work because they're both in the expansion area at the same time. So lots of coordination work making that work. So that's going on. The equipment delivery status, there's one change since I wrote this. We had the air compressor that supplies the air for the new CS equipment. Originally, it was a long lead time, and we're going to have to look for something else. The manufacturer came through, they were able to shift the model a little bit and get it quicker. So we went with that, and they have now received that equipment, but it's not the right equipment. And so that goes back on the list as an issue that we're working through. But they think we do have one in the States, different manufacturer that will meet all the specifications and be here before phase 1 opens. So April or May. So we're working on that. Let's see, and coming up right real quick, starting Monday, we'll have power shut down so that they can put some new breakers in some of the panels to support the energy project, so that shuts off power to some various panels in hospitals. So we've investigated all that and come up with a mitigation plan. So Monday at 6:30, we will have that for shutdown. But that's really kind of the starting point for several shutdowns: electrical, plumbing, bed gas, sewer, and all that. That's going to come right around the corner. So we're working hard on mitigating all that, making sure we understand what's going to happen when we do that. Yeah.
There's some pictures there, it looks like.
If you're ready for that, let's rush it.
That's in the tunnel. Those are all.
New tunnels or old tunnels?
That was the new section there. Yeah. So that's all equipment to support CS. We were able to put it down there where we can access it without getting in their way. And so those are all backflow preventers. And so we put in dual backflow preventers so that we can test one at a time and keep their equipment up, so there's never any downtime for them.
And is this sort of area climate controlled at all? Or does it need to be?
No,
So
it stays.
even with a 0-degree day for a couple of days, this won't have any
Oh, yeah. No.
freezing effects that'll cause us problems down the road?
Yeah, it stays 60 degrees about year round. Yeah. So that's where the sewer main is going to tie in right there, that lower black pipe. So they've got it to the point of connection, and we just got to plan that final connection. That'll be kind of impactful to the hospital. So we're still kind of working on that piece. And that's just some more backflows for CS. And yeah, that's them working on, getting ready to work on the EFS, they call it. So the siding on the hospital. And so they, that's all now plasticed off and heated, and they're working on it. And so that's some of the framing that's come a long way since that picture was taken. Yeah. They got all the walls up now. Yeah, the side of the building there, they got the primer coat on there. Now it's ready for, that section there is ready for the final finish. On the rough that they're having, that was quite a chore getting through that with all the weather, but they stayed with it and got it. So, yeah. Pretty
Can I-
impressive. Yeah, go ahead, Joe.
From our vantage point from Jason and mine, we watch those guys work and it is amazing. And I'm just thankful for all the work they do in all kinds of weather. And we're really getting our money's worth from Walker. I think they're out there
Yeah.
all the time. So it's impressive. And again, just dedicated hard work going on out in the elements. So.
We've got it pretty warm inside now, thankfully. Now that the cold weather's through, they're inside in t-shirts, it's warm enough.
Oh, yeah, just
The
maybe.
Rippers just moved to another cool job.
Yeah. The roofing, that was a big deal. They had to shovel the roofs to lay the roof.
Yep. Several times.
Yeah.
Right, John, you have a couple questions?
Ron, do you have the packet then in front of you? Page 23, do you have that? Very top of the page. I'm just looking for a little clarification on what you mean by that first sentence. In other words, is this a good thing or a bad thing? I just don't understand it. Has lead time into mid-May, but that is after phase 1 opens. Is that good or is that bad?
Yeah, well, that was what I was trying to figure out. And so that's actually a separate project that they're doing for patient monitoring equipment. So as they move patients around, it transmits data. And so I didn't know when I wrote that how impactful that was.
Okay.
And so it's,
You know now.
yeah, and so it's, if it doesn't happen by the time they open, they don't have that data now, so it's kind of an added thing. So we're gonna be okay with that.
And then on the next page, I have a similar type question. You're just a man of mystery. These various alarms going off, you end with the phrase, facilities were not notified and contractor did not cover detector. Again, is that good or is that bad?
That's bad.
That's bad. Okay. What should happen?
Well, so when they go into an area to do some work that was originally covered by our fire alarm system, you know, they're creating dust and vibration. And so you've got to take those things offline. And
So they are allowed to turn them off to prevent false alarms and stuff, or cover them up
Yep.
or whatever it is. And they're
while they're there, but they have to go back online at night. And so we have to be notified, one, to take it off so it doesn't go into alarm, because when it does, it causes, you know, all sorts of chaos in the hospital. And then we got to make sure it goes back online so that that protection is there.
I understand a lot better. Are we working through a system so it happens less often? Because it seems to be have a series of these back to back.
Yeah, it's daily meetings with them, you know, when that happens, we're bringing it to their attention. And Randy's trying to key in on where they're working so that they can remind them too, so.
Excellent, thank you.
So historically, when those fire alarms went off, I know the hospital would get a call from the fire department to see if they had to run over here, if there really was a fire going on. Did that happen a lot of times when these went off? Or did the fire department ever show up?
Oh, they did, yes. Yeah, I think the first one we had was down in the tunnel. And this detectors, and you kind of seen pictures of some of those tunnels, what they look like, and this was in the existing tunnel. And you have all these conduits, and above that is this detector. And so we get the alarm, and since it's in the tunnel, so you go running down there, it's like, where is it? And
So the
it
fire
took some
department
time
did
to-
get notified that there wasn't a fire, they contacted us.
Say that again.
But historically, if a fire alarm went off in the hospital, I know they would call the hospital to see if there really was a fire going on before they brought over the equipment to put it out. And I
No,
was just thinking-
they roll unless they hear from us. And so if you say, no, this was a false alarm, this is what happened, then they will stop. But if they don't hear from us, they're rolling.
Okay, so these fire alarms still are connected with the fire department, so they know they've gone off?
Absolutely, yeah. It automatically sends a signal out to them.
Yeah, no, I just wanted to make sure that even though they were false alarms, that all the fire alarms are still being connected. So that way the hospital consequently, the fire department knows what's going on. And since they're really close to us now over in Mountain View, if there is a real issue, they could hop in here real quick.
It doesn't take them long.
Okay.
Yes, that's all functional. It automatically calls out every one of those.
Okay, thank you.
Other questions for, about the building project? Thanks a lot, Mark. All right. Next up, we have our operations reports. We'll start with Dee Dee Utley, the Chief Nursing Officer. Dee Dee.
Good evening. My report begins on page 32. And a lot of the topics that we've already talked about have been areas that my departments have been working in. Obviously, our DOH survey, we've been doing a lot of work on those. Construction, I know Amy's area is moving along with our expansion project, and they're very complimentary of the collaboration and the communication. So I did want to call that out. QAPI, we've started on the expansion QAPI for 2024, and I believe we have our first meeting soon, Tuesday, next week. So we're really looking forward to jumping in with help from Mandy's department. We have a facilitator to steer us there. The only other thing I guess two things I'd like to call out that have happened since I submitted this for food and nutrition services. We have added a fourth facility for the virtual dietitian. So that's really exciting that we're able to provide a much needed service to some of our smaller hospitals in the state. So kudos to Jim and his team to be able to provide that. And then the last item I'd like to call out, which kind of goes with Manda and our workforce and HR, is the clinical educator began, Amy Morse, who is helping to drive our nursing assistant program. And she would open it tomorrow if I'd let her, or the state would let her. We have done so much work. We are having meetings with all the right stakeholders, and we're hoping to have that. We still have a lot of details to discuss how the program will actually run as far as bringing in the participants for it. And then, of course, some approvals. We chatted with Central Washington University about a potential for skills space versus our space. And I'm hoping to have something up and running by summer.
And just as a reminder that PCT position is a CNA position. So we have a high need for PCTs, and difficult to recruit, so this will be really helpful.
And then if there are any other questions, I'm happy to answer.
Any questions for our Chief Nursing Officer?
I'll give her one.
All right.
The code blues, what has changed that's any sense of why are we having more of that? Okay. But high stress.
I'm gonna look at Dr. Hobby.
I really don't know. I'm not sure how to.
Yeah, is it the growth in the community? Is it,
Higher acuity before people decide to come in for help or something?
yeah,
But we're having a fair amount of success with resuscitations. Or
we do a good job here.
it's gonna be very stressful for the staff.
And I know that's one area that the nursing directors are working with the clinical educators on more and more drills. And we're looking at doing drills in other facilities than just the emergency department or other departments. And just, tightening up the team and the roles and the responsibilities and reviewing what we're taught every 2 years when we recertify our ACLS cards. But yeah, I think we do a great job here.
Thank you.
I think I said this a few months ago when we actually had code blue in a public area in the hospital. If you've never seen that team respond, I don't know how you tighten them up anymore. They're amazing. So I just stood back and was exceptionally proud.
How do people tend to respond in a situation like that where it happens in, where clinical staff aren't already? How many people decide on that?
It's just an overhead page and whoever's available. It could be quite a few, but there's usually a gatekeeper and there's somebody, you know, who takes that lead. And of course, you know, being the size we are, we do try to dispense staff back to their departments if we don't need them. We do a really good job here.
John, to your point, just jumping in here, with Experience Healthcare, one of the things we do on the final day is we run a drill, sometimes countywide, sometimes within the organization, always with our air medics, where the students watch a full code that we are training on. And so they're able to come in, they see the response ranging from what happens with fire and EMS to coming into the ED, watching that response. How does the code go? We use it as the training opportunity for staff, but it's very enlightening to students. And we take it as far as the air medics come and how they package and transport patients. So it's definitely one of the highlights.
Thank you, Michelle. That's very interesting and very strategic of you to end with something so dramatic for that time. So thank you.
Uh-huh.
Any other questions for Dee Dee? Thank you, Dee Dee. All right, next up, we have our Chief Ancillary Officer, Rhonda Holden. Rhonda, you're up.
All right. Hello, everyone. My report begins on page 35. And I think one of the important things that I need to add this evening is you're probably aware that hospice contracts with Hearts and Hands of Kittitas County for our volunteer services. And we have received a termination notice from them that they are no longer able to provide hospice volunteers for us. And that is a condition of participation for CMS to be Medicare accredited for hospice. So we will be working internally to see how we can absorb that, both with help from probably human resources and staff development, and then also seeing what type of a volunteer coordinator we might need to hire. I don't know if you're aware, but they did receive resignation of an executive director and their volunteer coordinator. And so that is what led to the decision that they couldn't provide those services to us any longer.
So there's still there's still people who can do that kind of work. You just don't have the administration at the organization?
Well,
So in
they
other
still
words-
have, they still
Oh,
have
sorry, go ahead.
volunteers on their
Yeah.
roster,
Right.
but they don't have a volunteer coordinator providing that oversight to them. So that is pretty concerning. I am actually the vice president of their board, so, and working, of course, with our hospice. So I'll be helping them as much as I can if they have any concerns. They will be doing the best that they can, but I believe their termination letter was accepted by Julie for Monday, the 29th.
Rhonda, what sort of roles do the volunteers fill for that arrangement? What do they do?
Well, they can do some type of office work, but primarily what we use them for is visiting in the home. So they may sit with a patient so that a family member can take a nap or take a shower or go shopping, or they may want to do the grocery shopping for a family, or just read a book, play music, just really be there and you know, be a friend and a companion to them. The other piece that they play is they have the No One Dies Alone program in the community, so that if someone who is dying doesn't have a family member or friend that can stay with them, they have volunteers that they can put in the home around the clock in order to have someone there with them when they pass away. So pretty valuable. They do also support bereavement programs. You know, we do have a bereavement program with our hospice, but they do supplement that. So I'm hoping that we would be able to volunteers helping with that some as well, or the volunteer coordinator helping with that.
The volunteers are still there. We just, somehow there needs to be some structure to coordinate them.
Right. Well, they would need to come into our organization, so we can't just take them. We're two separate organizations, but we could hopefully have them apply to to be a volunteer for KVH and then do all the things that we have to do, criminal background checks. They're basically treated like employees per the CMS regulations. We have to have an application, an interview, background check, infectious disease screening, all sorts of training that they have to go through. So it is quite extensive. So Hearts and Hands of Hospice is getting ready to send out a letter to all of the hospice volunteers, letting them know about this and encouraging them to apply to KVH so that they could continue to be a volunteer with us.
Is that organization shutting down? I get that the executives resigned, but are they closing their doors?
They haven't made any type of announcement according to that. Right now, they're looking just at the hospice volunteer portion. And for the remainder, they do still have a 30-hour-a-week employee in Ellensburg and someone working a couple of days a week in Clay Elum.
We have, Rhonda's kept us informed and we are doing some contingency partners.
One skill that's particularly useful in the volunteer is the ability to lose convincingly in cribbage.
Any questions for Rhonda about her report? Go ahead, Jeff.
Rhonda, you'd mentioned that the properly sized gurney might be here by the time we're meeting tonight. Did it work out? Did we get the
Well,
gurney?
we have a properly sized one, but unfortunately it contains metal that cannot go into the MRI. So we are back to ordering another one.
Yeah, okay, thank you.
Yeah.
Anything else? Thanks a lot, Rhonda.
Thank you.
Next up, we have Stacy Olea. If it's okay, Stacy, we'll just do your regular report and then go on to the presentation.
Sure. Just a couple things to point out. One, I have no nursing positions open. We are really excited. We've been able to fill all of our clinic nursing
Don't
positions.
say that out loud.
I know, I probably jinxed myself, but I think that you really are.
Steal.
Yeah, hey, I took a couple from you. The next thing on women's health, we do have one locum who is willing to, while he is here covering OB call, will actually be in the clinic providing GYN services. So we are able to offer GYN right now. It is limited to that locum schedule. And we are working with several other locums to see if they'd be willing to support that service also. So that's also good news. Otherwise, I am open to questions before we move on to the presentation.
Stacy, I see that GYN not accepting new patients except maybe this. The locum will be providing new patient services
Will-
established.
He will be providing new patient services. He was just here this week, so he was here Tuesday, Wednesday, Thursday, Friday.
Okay, how about OB? Are we accepting new OB
Yes, we are
patients?
accepting patients and we are hovering right around 30 deliveries a month right now is what we're hovering around for patient load.
I'll just say, I want to thank the staff of Women's Health and Dr. Hibbs and Stacy. We had a great meeting this week with the staff looking at the OBHG relationship and how things were coming together. And they're just all in, and I'd like to express on their behalf their appreciation of the board support for OB services. So their sleeves rolled up, doing the work and hanging in there with us.
Any other questions for Stacy about the report or the dashboard before we have a presentation?
I will say, it looks as though you're one of 50 who was invited to attend this rural health clinic in DC, and so congratulations. for
Thank
being
you.
part of that.
I'm very excited about that.
Yeah, that's impressive.
Anything else before we move on to the presentation? Okay, so as we're hoping to hear back on the phones, and we appreciate Stacy doing that, and Angela, you coming to help with that. So the floor is yours.
Great, yes, so some background on our phone project. at FME, we rolled this project out with the help of Leanne November of 2022. So we've been doing it just a little over a year now. And if you need to know, we started in October with chartering, trying to solve the problem with our negative patient experience, long holds, trouble with calls not being answered, high volumes, repeat call being high, return calls being delayed, and calls just being disconnected. And we partnered with a lot of people in the clinic, in quality, in IT. And so it really has been taking a village to address the problems that we're having and moving ahead. So where we were pre-project, we were hearing daily, and I hear that the board members were hearing probably daily about some of the troubles that they were having, getting connected to the phone, getting connected to staff at FME, long call queues, and really just reflected poorly on our customer service expectations. And so when we started tracking our numbers, and we have a spreadsheet that is now over a year's worth of information that we track. And so we're using that to kind of measure how we're doing and where we want to go. So before we started, call volumes were pretty steady. Mondays being our high call volumes with over 500 to 600 calls per day on Mondays. So pre-project staff morale was feeling pretty beat up, frustrated, wanting to do better, having to deal with patients who were also feeling frustrated, beat up, and wanting us to do better, and feeling just kind of really exhausted by being constantly barraged with the phone and complaints about the phones, and continuing to come back day after day and answer the phones, and feeling pretty worn out by the end of that. So where we're at today, we have had 12 team meetings. We have an action decision log that we've been working on that has over 100, well, has 100 action decision items. 75 of those items we've completed. 16 of those items we're still working on. And we've identified some parking lot items, things that that tie into our phone project, that kind of, side projects or things that we've identified that we also want to work on in the future, including our wait times or turnaround times for responses from the back of house teams. So the MAs and the providers and the nurses, our PSR staff answer the phone and take a message. But that message then, sometimes has to go to 2 or 3 people to be able to get an answer and a resolution, and that resolution being relayed back to the patient. And so how to streamline that process for the patient experience. We did participate in a site visit to Mason General over in the Sheldon area. And the reason that we went to Mason General is that they use the same Cerner system that we do. They used to in Community Works, but they now have a separate domain, but they have had some of the same issues, and we were really interested in how they were addressing some of the complaints or issues that they were having and working in the Cerner system. We learned a lot. They have created a call center for their phone system for their clinics, and they have kind of gathered together their referral coordinators and their phone people and their prior authorization folks working outside of the clinical space, and then keeping a few people within the clinical space for those check-ins, registrations, and then those follow-up appointment scheduling as the patient's leaving. And so we were really impressed with the way that they were handling their work. They answered a lot of questions, and we learned some neat tricks that they were doing with Cerner that we're excited to implement for our PSRs. One thing that they do, or that they were able to do, is when you schedule a new patient, you can make that appointment show up in as a different color in your screen. So it makes it really easy to identify how many new patient appointments are scheduled each day, versus having to, everything is the same color and having to read all of the comments to see what type of appointment is scheduled. So we're excited about kind of just those easy things that we learned.
The other thing I'll add about Mason General is they have a good mix of primary care and specialty clinics. Their overall volume is lower than ours for clinic visits, but it gave us the opportunity to see how they manage that across multiple types of clinics.
Yeah. Thank you. So what we feel significant changes from the start of the project to where we are today. We have dedicated 4 staff members to answering the phones, and that's on a daily basis. That is priority number 1 for our team, for our PSR team. We also have 1 to 2 of PSRs who are dedicated to answering the voicemails and processing those voicemails. We partnered with IT to come up with a solution for a visual voicemail that's HIPAA compliant. The way we were able to do that was using the Zoom app, and they have a phone feature. What that does is our voicemails go to that phone feature, and as that voicemail is left, Zoom transcribes it so you can read the voicemail and hear the voicemail, instead of having to call into a voicemail system, listen, and dictate the message. So that has really been a time saver for our PSR teams.
The other thing it added is it puts a visual count for how many voicemails are actually there. So anybody who's logged into that Zoom system can see that number as it slowly increases. And on Monday, they'll watch that number climb. So it gives us the opportunity to say, hey, we need to get some more people working on voicemails.
I have the Zoom app I'm tied into the FME pool. So as I am working and I can see the number increase, and that is another thing, multiple people can be into that Zoom voicemail and addressing those voicemails as they come in. I can see that the number is going up. I can quickly do just in time, hey, what's going on? Do you need help? Or, is there a problem with our system? We've moved the 4 team members who answer the phone from the clinical space, our PSR lead and our voicemail PSR to the annex. They're upstairs in that loft space. That was a really positive move for our PSR team. They're able to focus on answering the phone and processing those phone calls, versus when they were in the clinic, there was constant interruptions. Hey, can you do this? Hey, can you do that? And so that has been a positive change. As we went to the 4 dedicated PSRs, we were able to, with a spreadsheet, look at the data, and we have decreased our previous duplicate call volume from 40 to 50% duplicate calls down to about 29.5% duplication.
Could you please remind me what that means?
So we were able, in our call log, to look at how many times an individual or a unique phone number called us. So one of the things that we were tracking is if that patient had to call the clinic on the same day 3 or more times. So if they've called 3 times or more, we're tracking that, and we consider that like a duplicate call.
So these are people impatient because they haven't received a call back?
There's usually a variety of reasons. Sometimes there's duplicate, and we've done a deep dive. We've looked at patients one day who called 41 times in a day, and asked that patient, you know, why did you call 41 times? A lot of times patients who are have those real high numbers are just spamming us. They're spamming us, and they want a live voice, especially if we're on a Monday or through the lunchtime and they want somebody to pick up. They're not leaving a voicemail and giving us a chance to call them back. So that's usually those high call volumes.
I will say some of it though is also just interaction, is an
Yeah.
MA calls to give you results, you don't answer your phone, you call back, then MA isn't available, and they play phone tag.
Yeah.
The rest of the clinics run anywhere between 20 to 25%. So FME was about as high as 45% callback. So we've been able to move that number closer to what we're seeing at our other clinics.
And I feel like the decrease in that number is with the dedicated staff focused on answering the phones. We're picking up more of those calls the first time, so the patients don't have to call back or don't feel like they have to call back.
I remember early on, one of the numbers that really stunned me was of these hundreds of calls, they each take it's an average of like 6 minutes or something.
Yes, yeah.
So these are not quick transfers and things. So they have to have that focus to answer the question and figure out what the patient's asking.
Change in the last year, we feel like, well, I know there's been a definite decrease in the complaints from the patients. I do occasionally still hear that I can't get someone on the phone. And then I will check in with those people. You didn't get somebody on the phone, you left a voicemail and we called you back. Well, yes. Okay, so the system is working, but we didn't, that was, you know, they were the 5th caller, and the 4 PSRs didn't pick that call up.
I don't know if I'm a representative sample, but I've had occasion to call in and the person picked it right up.
That's because they know it's you.
Yeah, well, I was,
You have a special phone.
yeah, I mean, maybe that's it. But anyway, it was very different. I never complained about not getting someone on the phone. I just yelled at a wall. But yeah, no problem at all. I mean,
Yeah.
so that's.
So it's good news. Yeah, I feel, you know, where we're at right now is, you know, with 4 dedicated people, I feel like we're probably picking up 80% of those calls, and there's still that 20% that are the phone's ringing and people are being, there's no one to answer that phone. I will say too, that the 4 people are dedicated to phones. The people who are helping with voicemails, if she doesn't have a voicemail, she's answering the phone. The phones still light up at the front desk at FME. If the front-facing PSRs who are focusing on registration aren't busy forward-facing a patient, they can pick up a phone call. The phone rings at my desk. I know people are busy. It's lunchtime. I will pick up the phone. So we're still all focused on phones, but the primary function of those 4 is to answer the phone.
Is there a dedicated staff who are phone people are kind of rotating position?
We really do leave it to the staff to kind of tell us if they want to rotate around. I have a few staff members that they really like just answering the phone or dealing with voicemail, and they don't want to move around. I do have other staff that I don't mind answering the phone for 2 weeks, and then can I do 2 weeks at the front desk? So I do let them, we do try to get them rotated around and create a variety, also keep their skill sets in both areas sharp. because there's a lot to registering a patient and steps.
That the ability to focus on phones all day is a talent and a skill, one that I know I don't possess, so it's striking to me that someone, that's their thing, I'm so impressed. So,
There's,
good for them.
yeah, we definitely try to take into account that answering the phone every day, for 4 months is probably pretty harrowing, and that's not everybody's cup of tea. So we do work as a team to make sure that we're rotating through jobs and positions so that we feel fulfilled. Yeah.
It's nice to have those options there.
Yeah, and I feel definitely the staff morale within the PSR team has improved, and I have heard from the staff who do answer the phone, being in the annex space is better, that they enjoy being able to focus on that phone call and helping that caller without having all the interruptions of being all upfront at the clinic.
Quick question for you. If somebody calls in and leaves a message, do they get any feedback of, there are 8 people in front of you, or it will be approximately 30 minutes? Do they have any sense when they hang up when to expect to return?
So we don't have that ability with our phone vendor at this time to know, like, you're in a queue or you're the next caller, or what the wait time is. We're hoping with Consolidated, they did just get purchased by another system, another vendor, and that's Jeff is working with that new vendor. I believe that they come on in March to see what kind of solution or phone system options that they have for us.
I know, Angela, we used to have in the voice message that we would try to return a call same business day.
Yeah.
So I think that's what we're telling them, is we are trying to call same business day.
But I've said this a lot of times in a lot of our meetings, when you have something up there that has abbreviations in it, I think it's really important to say what the abbreviation is once when you're talking about it.
Okay.
So if somebody's listening to this meeting and they don't know what the abbreviation is, they'd be concerned. So PSR is Patient Service Representative.
Yes, that is correct.
Okay, well, I just wanted to make
Thank
sure
you.
that if anybody's listening to this meeting, they know what a PSR is.
Thank you. Yeah. Yes, so
Okay.
Patient Service Representative, that is the job description and the title that we have for our staff in the clinics. It's
Right, yeah.
a broad job description. It encompasses all of the things, but at FMA, we have kind of parceled that out into registration, phones, voicemails, and medical records.
Okay, thank you.
Yeah.
Angela, I'll add something too. So some of the functionality that John was talking about, with wait time queues and others, is also in many cases a separate application. Those are call center type applications. So when you have like a big call center, then you have to purchase an additional type of application that manages all of the wait calls and the call queues and all of the other things that come along with that. So sometimes people hear that, they have these functionalities, but in the background, they're calling from a big call center that's set up with all of the other additional technology. So which we can't have at some point. So.
Thanks, Jeff.
Yep.
We work closely with the quality department to review any customer concerns or complaints specifically regarding the phones. The quality department hasn't received any of those complaints in the last 6 months. We do review our Press-Ganey information as well. There were 2 complaints in Press-Ganey in the last 2 months about the phones.
Every quarter I read a whole lot of Press-Ganey comments, and there's a very clear difference from a year ago or 2 years ago to reading the comments now. The comments report, there's a lot of comments about the phones, and there's almost nothing now. they can really feel it.
I still do have some patients who come in person to schedule. We're still dealing with some of that historical perception of no one ever answers the phone. I think as we continue to improve and work on that focus, we'll be gaining that trust back, but that will take a long time. And then, of course, auditing this high volume repeat callers. Usually what I hear is I want to talk to someone in person and I don't want to leave a voicemail. So even though that is an option and we're quickly addressing those voicemails, sometimes people just refuse to leave a voicemail. And I'm sure we all have family members that we can think of. My dad would probably be the #1 offender. You know, I'm just going to spam you until you answer your phone.
Does the answering team have the ability, say, if I called on my lunch break when I'm at work and I make calls during my lunch, I would return to my duties and perhaps be unavailable by phone until maybe after the time when the phone team has gone home. Is there an option to say, you know, can you call me tomorrow at this time when I know I'll have a break, or to avoid some of that phone tag, or is that something we can look at down the line if it's not currently?
Yeah, I think that's a great, great idea to look at down the road.
Just thinking of one of the reasons I might be a repeat caller, because I know I have this much time to get through.
Yeah, absolutely.
This is an impressive amount of work you guys have done ironing out the system.
One thing we've really done too with our patients as they're registering or we're checking their registration, we're asking them if they know about our patient portal, and I think we are really increasing our patient portal access to. So not only verifying their phone numbers, but letting them know that they can see their own lab results, they can send us questions, they can do a lot of things that they might historically be calling to get that information that they can access if they have the portal account. So go ahead, Mandy, please. This is kind of just some data from the last 2 months. And then when we went to 4 PSRs in August till now, I calculated the average duplicate calls to be 29.5%. That one outlier where we were up to 60% duplicate calls was the day that the phones didn't work, and it was at till 10 o'clock that we didn't have phone service, and so we got a lot of calls that day. Yeah. We've improved. We've got dedicated phone staff. They feel some relief. They're excited about the improvement. The pictures are of the space up in the annex. We are continuing to work with our PSR team and have team meetings and working on that action decision log. We're working on process, balance workload, and making the process streamlined. Patients are nicer, which is always a plus. And they're, I think, continuing to be confident that they see the improvements and that we will continue to improve. Next steps for us in this project, we are ordering furniture for the MAC annex upstairs to formalize the space. As we talked about earlier, the phone company was purchased again. And in March, when the new phone company, which is local in Tacoma, when they go live, we'll be able to kind of talk to them about available technologies. We're going to be doing some tact time studies with Leanne to review the impact of dedicating the staff to the phones and helping to continue to balance the workload of our patient service representatives. As I said, we've uncovered more work to do, which will be continuing to improve the time that it takes to get a response to that patient from our MA, RN, and provider team. Monitoring the data and feedback from patients and staff. looking at our referrals, and next step, checking to see if we need to have an option or dedicated voicemail for people that are calling regarding referrals or to get a hold of our referral team. That was something that we had in the past, and then as we changed our options, we took away. We're hearing from some of our community partners that that they'd like to be able to get right to the referral team. And so we're working on that as a future state. And we're really looking at, do we want to create what we call a patient experience center? Not just a call center, but an experience center. What experience do we want our patients to have? What does that mean? And is there implication for artificial intelligence technology in the future to be available to help us with our solutions?
What does the patient experience center look like in other organizations? What else would they do?
Mason General was a really good example. They had a team that their referral coordinator people were there, the people who answered the phone and did the scheduling were there, and then they had the people who did prior authorizations, and they were all located outside the clinic, one dedicated phone number that then broke it out into those 3 different groups. So if instead of calling cardiology directly, you would call this one number for an appointment and they could schedule you at any of their clinics.
Okay.
That concludes our presentation for the update.
There are additional questions?
I was just going to say thank you for taking this so seriously and working so hard over last year to find solutions.
Can I just ask from the board's perspective, have the complaint level come down or your neighbors? I think this is kind of a no news is good news.
I was just going to say that they put so much work into this, and I mean, you would hope that people say, yeah, this is the best call experience ever, but often the best to hear is that people don't complain.
People just like to complain, they don't like to compliment. So. But maybe with the Monday crunch, you need to rotate through board members, come in and do like a telethon type thing. We come in and spend our couple hours answering the phone to help with the crunch.
If you've ever spent any time up at the clinic or know me very well, I'm somebody that dives right in. So they always laugh because they'll say Angela's touching everything. I do occasionally answer the phone myself, and sometimes when it is super busy, that's what you just got to jump in and help.
Bob, did you have a question?
Yeah, just a comment. I mean, I feel like there's definitely been some significant improvements in that process, and I've heard that firsthand from folks who have been frustrated in the past. So I think we've kind of turned a corner, and like everyone else said, I think you just put a lot of work, and this is not just about answering the phone, right? It's more than that, and it is that the first connection that the patient has with our hospital, really. Yeah. So I think you've done a really good job and appreciate the work, and just trying to find that secret sauce, and we still have a little ways to go, but yeah, I feel really good about the direction. And from a user also, right? I've noticed that too. So really happy. This was the things I would hear is you can't even get, we don't even have providers yet. You can't even get a phone call in to, try to even make an appointment. And I've had people specifically tell me that there's a difference. And when people actually come out and say that there's a difference, that means there's a lot of other people saying the same thing. So good job.
Thank you so much.
Any other questions? Thank you very much, Angela, for coming by. Thank you, Stacy. Okay, we move on then to support services, and we'll start with Michelle Worrell. Michelle, you're up.
Well, before Angela wants to leave, I want to echo what everyone else is saying. We would see things on a very regular basis through Raiderate and social media and things like that. And that has, knock on wood, completely died down, and it's all because of the efforts that they're putting in. So kudos, great job to everybody, and thank you. We really, really appreciate that. The other things I wanted to give a shout out to Mitchell Rhodes, and I know Ron and Amy Diaz were helping. We've been talking for months about doing a capital request to the legislature, and we've been anxiously awaiting we have to have specific links and forms to do that. Representative Ybarra checked in with us today, and we had 8 hours to complete it from the time that he submitted the link. And thanks to everybody's dedication and some pre-planning, Mitchell submitted that at about 5 o'clock this evening. And so kudos to that. We're hoping to get some funding to support the surgical services complex refresh that's going to be happening this spring. So we'll keep you posted there. I also just wanted to update through conversations just with Dr. Martin and Amanda and to make sure we had the best information possible on provider huddle and the processes in place. That did not go out before this board meeting. We are actually going to start that in February. We have all of our content outlined, plus whatever comes out of this meeting, and it'll give time for Dr. Martin to review it, HR to review it, and just to make sure that we're putting our best foot forward. So that will be going out.
Michelle, what content do you include in that?
So I could pull that. I'm working on the KBH huddle right now. We talk about things that are specific to the provider community. So for example, in the surgical expansion project, we're going to be adding that second CT and an MRI. And with that equipment comes new additional clinical capabilities. So we'll be highlighting things like that. So we get a little bit deeper into things that matter to them. We talk about physician leadership training that Amanda has touched upon in her reports through Valor. We also just talk about community activities. So like, unfortunately, one of the things we're going to be reporting is the passing of Dr. Solberg's wife, because this also is meant to go to retired providers. And so we want it to be a way that we can communicate what's happening at KVH for active providers, as well as keeping people engaged with each other. So that's just an example. Does that answer your question?
Thank you. Yes, it does. Thanks.
Okay. And then the other thing I just wanted to call your attention to, I think Mandy put a flyer there in front of you. 4 years after the opening of the MAC, and we are finally doing an open house on February 20th. We would love to have your attendance and or participation. We're looking for people just to greet the community when they come in. No heavy lifting, but we are doing that on February 20th. We'll be doing tours. The MAC staff and senior leadership is doing the big lift here. An engineering facilities team, they have done walkthroughs with my team and with the clinic staff. We're really creating checklists to make sure that, it's been 4 years since we've opened. So let's make sure that it's looking nice. We've got things cleaned up and put together. Engineering is just cranking through that list and is doing a fabulous job. So thanks to them. And we hope you'll be able to join us. Other than that, I would be happy to take any questions you have.
Questions for Michelle? Thank you very much, Michelle.
Thank you, guys.
Next up, we have Jeff Yamada, the Chief Information Officer. Jeff.
Yeah, welcome everybody. So my report starts on page 48. I included a lot of end of year stats, as you can see. Really so we just finished up our annual security risk assessment. That's probably about a month-long process to download all of our documents, policies, procedures, lots of meeting with the vendor that we use for that. It's a 2-day on-site visit for them to go through our facility. Unfortunately, we had to do that remotely this year. They were in Seattle, stuck in Seattle during the big snowstorm. So we improvised and did that remotely with video, so using technology. Outside of that, we'll get a report back probably in a couple weeks here. an official report on how we did with our security risks. That said, we're doing a lot of cybersecurity prevention, so that continues as well. And then we are still heavily implementing the single sign-on or badge tap. We're just about done with the hospital. So we finished up pharmacy last week. We are in ED right now, and in imaging. And once those areas are done, I think we have some areas like engineering, some smaller areas, engineering and dietary to finish off. And then we'll probably take a short pause and then move on to the clinics. And so we are totally progressing there.
Jeff, I have a question for you. Like, you send out these simulated phishing attacks, and if you report it, we get a little congratulatory message, which is nice. What happens if someone tries to open the attachments? So in other words, they're falling for it. Or they get a note what kind of note do they get?
They get a oops message, I think.
Do they get an invitation to training?
Yeah, and then go
Yes.
straight to training.
I may have been somebody that's fallen for one on my phone, and we get a nice little message that says, oops, you've clicked on a phishing attempt. You're now signed up for this great training.
Does one's heart jump into their throat when they see that? Like, oh, just.
Yeah, we do have
That's not
as in my report, we do have a list of what we call clickers. And so you fall on.
You don't want to be a clicker.
Oh, wow.
Do you get a special little badge buddy for that?
Oh, there you go.
All right. Any questions for Jeff?
Jeff, I was going to ask you on the infrastructure section, you're talking about your new fiber runs that you're doing and how it will help protect against malware and viruses. Just wonder if you can elaborate on how that works and how that helps protect us.
Well, there's two. So we have a co-located site. It's not a true offsite data center, but we have redundant equipment over at Radio Hill. We have a room, a data room there as well. So the fiber.
Jeff, real quick, I just said that the whole screen, it started to say your bandwidth is low.
Oh.
So when we started to talk about infrastructure, it started to go down. So sorry to continue. Yeah.
Oh, yeah. So anyway, we have a fiber run between the hospital and Radio Hill. So we have redundant equipment up at Radio Hill. Part of, and that goes along with not only our backup data storage, but also with our VDI, so the badge tap. So if we were to get hit, within the hospital, or there's an issue with our data center at the hospital, it automatically, once we're about 95% done, it automatically transfers over to the location over at Radio Hill. And users don't even know there's a difference. We're also working on a immutable backup site, which we already have. And so that's where we can back up to a environment that it can't be touched by ransomware. It's not connected to our network, so it's separate.
So that area, that would be offline,
Yep.
that chunk to keep it from being penetrated if somebody got to our main system.
Yep, got it.
Good. Thank you, Jeff.
Yep.
Other questions for Jeff? Thank you very much, Jeff.
Thank you.
Next up, doing double duty tonight, is Ron Erlacher, Chief of Facilities. Ron.
Okay, well, my report starts on page 53. Says, point out we've made some really good progress with getting our critical PMs completed. So we're now on track. And I'm pretty confident that going into 2024, we can keep that trend going. So applaud Trent for his work on it. So I just wanted to point that out. In projects, some updates, the lab project, new analyzers is now underway. In that, and on the 5th of February, we will kick off the Family Birthing Place TI project, and also the CCU TI project. So They're getting new flooring, ceiling tiles, paint inside the CC rooms. CCU. Two of them will be held off because we also have the dialysis project that affects two of those, so we'll coordinate those new finishes with that project on those. Those are updates on that. Outside of that, does anybody have any questions?
Can you remind me what PM and PE stand for?
Preventative maintenance,
Thank you. And PE is.
planned event. So
Got it.
there's
Okay. I don't write
Thank
that
you, Erica.
down.
I'd also like to thank Trent, the fire and life safety survey that he's been working on. He has been following up with daily notices and announcements. It's all over the internet. Thank you, Michelle. And he's also been wandering around with his camera taking pictures of not violators, but violations, and sharing those with department directors. And so he took that to heart, and Trent has really been doing a lot of work and great work on that.
Any other questions for Ron?
I just appreciate all the little updates, how each one of the little projects is doing. So thank you for keeping us up to date on that.
Yeah, thanks for the detailed report, Ron. All right, thanks a lot, Ron. Okay. Next, we move on to the medical staff and our chief of staff, Dr. Afika.
My report is on page 64, one-page report. The medical executive committee reviewed 10 credentialing files. Most of these were reappointments. Now I'm happy to field any questions. Ask any questions.
Everybody's had a chance to review these, I assume, online? Okay. Do I have a motion to approve this list of initial appointments and reappointments?
To approve.
I'll second.
All right, moved by Erica, second by Terry. Any further discussion? Okay, all those in favor of approving this list of initial appointments, and reappointments for practitioners here, please say aye.
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 All right, thank you, Bob. Unanimous, thank you. Anything else, Dr.?
I think so.
All right, appreciate it.
Happy here.
Thanks a lot. Happy to help you. All right, next up then we have our CMO report. Dr. Martin.
My report begins on page 66. I need to correct a factual error. We did not fly any providers to Yakima. The soul that we thought we were going to have to do that for decided that she knew how to drive in snow. She's from Alabama, but she successfully made it over the pass despite the conditions. We did have one interview that we had anticipated doing that wound up going from an in-person interview to a virtual interview. The interview went quite well, but the applicant spun out on the pass, talked to state patrol, drove back to Seattle and flew back to LA. But still did the interview the next morning. Other than that, I have nothing really to add. I'll take any questions.
Any questions for Dr. Martin?
Is there anything additional you want to talk about on OBHD's ramp up?
We actually had a very, very productive meeting last night, and provider that I was just referring to has informally expressed an interest in working for us, but not for OBHG. So we met with them and discussed a hybrid model that they're open to. So
because they've had a little challenge completely fulfilling.
they've had a market challenge.
Yeah, I mean, like the rest of the country. Yeah.
Exactly right. They're fighting the same shortages we are, and most of their staffing has been with locums that have been very, very expensive, but we've got
Hard on everyone's business model.
Exactly right. Except for the locums agencies. But we have a full calendar. We're staffed at least through April. But we're revisiting the model because what we're hearing from them is that the OBGYN workforce has evolved And so much like internal medicine, where you have a lot of folks who want to work in hospitals and a few folks who want to work in offices, that same split is occurring in obstetrics. And when we ask for them to provide somebody to cover labor and delivery and the office, a lot of their candidates find that a non-starter.
Which wasn't the case a year ago or 18 months
Yeah,
ago.
but it's what you were speaking about last night also. Is these people can go home at 5 o'clock and be done. It's an attractive choice.
And even before I came here, the laborist movement was taking off. And I knew a lot of OBs that were saying, you mean I can just be there and not have to come in at 2 a.m? And you can't really blame them.
Yeah.
It's just a very different world than when I trained.
Thank you.
Full-time admin now?
February 22nd will be my last day of field work with hospitals. Okay. I have a teaching commitment. I have one more resident that's rotating with me, and that'll be the capstone.
Okay.
And it looks like Dr. Woodard is
Getting
finding a place.
Getting on swimmingly. I've spoken to him, Dr. Hibbs has spoken to him, and staff have spoken to him. We're all giving him the same message, which is if you have friends in Wenatchee like you,
Here's the call.
Any other questions for Dr. Martin? Thank you, Dr. Martin. Next up then, we have our CFO report. Jason Adley. Jason.
Yeah, thank you. And I think first, Julie wanted to comment about a conversation with Dr. Schreier.
Yeah, so I had half an hour today on the phone with Congresswoman Fryer and talked, this was a follow-up to a call she'd been trying to get together with Dr. Martin, and we're finally able to do it, and I believe we were heard. Because we expressed our frustration with some of the behavior that we're seeing among health plans, among the 340B pharmaceutical manufacturers. So this was a follow-up to that. I did extract an agreement from her that she will write a letter of support to CMS with regard to the clawbacks that they did on COVID testing. If you will recall, we held all of our patients harmless on that and took a financial hit when CMS did that. She's also going to have Amy from her DC, I believe Amy's out of the DC office,
yes.
See if she can identify other hospitals that experience the same thing. So it was productive. It was frustrating. I think breaking through the frustration that she was hearing from Dr. Martin and the others that were on the original call was really about her vote to support a site neutral bill and her position on energy and commerce. And it was very disappointing to us for all the reasons that we know that site neutral is a bad thing. So I heard from her and she heard from me. And again, we stuck to workforce issues and financial issues. So I always appreciate how tuned in she is to healthcare issues, and she continues to be very, very focused on those. We're still missing each other on site neutral. We may be missing each other on transparency and the No Surprises Act. I think she's really surprised at how HHS has chosen to implement the No Surprises Act. So I know there are some dear colleague letters going around that they're hoping to get. So I appreciate her time and the opportunity to vent.
How often do you have an opportunity to interact with her?
We try to get her out to the hospital again, probably 2 to 3 times a year in a non-campaign capacity. So when she calls, she really does stay very connected with the hospitals, and we're hoping to get Snoqualmie, and because they're also very close to her headquarters, so maybe do some group hospital work.
Last April, we were in her office talking to a staffer about voting against the site neutral.
Yes, we lost that one.
Alas.
Yeah.
Do you know why she has the stance she does on that?
Well, there are a lot of advocacy groups. The data between what a hospital outpatient department has to do and what a private equity group or a large private practice is very, very clear that it is not a level playing field. In the middle of that, you have the patient. And I think she's trying to carve out the independent community hospitals and trying to carve out her rural facilities, but you still have the patient in the middle of that. She also has expressed how differently she thinks this is actually handled in other parts of the country where there's a lot more for-profit healthcare and a lot more for-profit systems. So she's dealing with Congress people from all over the country who are in very different situations. Thank you. Appreciate being able to hijack your report. No.
So my report starts page 67. December and ending the year pre-audit December financials. December we ended $607,000 loss. It was actually better than I had anticipated going into December. Adding back investment returns was just a $74,000 loss. We're still very positive for the year, ending at $4.2 million positive bottom line.
And you're tracing most of that to this providers fee accounts still?
Yeah, costs are with a lot of the providers, agency labor, staffing shortages, turnover, supply chain inflation. It's really very multifaceted, yeah.
Okay, thanks.
So ending the year, we are assuming a $700,000 receivable on the Medicare cost report as well. So this one year, I really don't have a good judgment of where the Medicare cost report's gonna settle. My gut says it's gonna be much larger than 700,000 back to us, but I don't have anything to lean on.
And that's a couple months before we'll have that answer.
Final is May 31st, when we submit by, yep. Still have some ambulatory providers on FMLA. More significant, we had a lot of people just taking time off in December. So we do have we have the holidays with December, and then we also have a end of the year use it or lose it PTO type of arrangement. So anybody that's close to that 200 hours or over, we end up taking more time off at the end of the year. We can see that in our FTEs, where we had 100 FTEs of non-productive. That's people taking time off. Non-productive as they're not here and working. Sick time, holiday time. PTO is the non-productive FTE, which was, I think, about 30% higher than a normal month we would run. So in general, we were just slower. We had less services, less people here, so most of our statistics were also low with that. Inpatient days were up on average, 4.2 days, but we still ended the year at 3.8 patient days for the year, and our critical access hospital requirement is to be below the 4 days average per year, so we will meet that. AR increased in December. Most of the reason of just December spiking up is the people out on leave, so PTO, a lot of people were out from the billing office in December. And then both on the payer side as well, they have people out not processing the claims. Again, just some profile changes on the income statement. You'll notice purchase services are actually really low this month, and that's because we implemented the new GASB 96 accounting rules for software subscriptions, right of use assets. So it actually puts them as a liability and an asset on our balance sheet. And then we have to expense a interest and a premium each month or principal of interest that's rolling up to the depreciation line. So you'll see depreciation's up, purchase services are down, and then that'll continue to be accounted for that way going forward. And there was a similar change last year. It was with physical assets and physical leases. We had that accounting change. This was the second piece of that. Days cash on hand decreased 192.2 days, or to 192.2 days. And that decrease is just going along with the expansion project, a significant ramp up in the expansion project spending. So that's anticipated to decrease throughout 2024. And a lot of that cash is from our debt service that we took out for this project. Some other highlights is just the continued changes with the profile change of our financial statements. So investing in the EAY, Emergency Associates of Yakima, Evergreen Anesthesia, Big Hospitals Group, Rural Physicians Group. Evergreen Anesthesia is a minimum guarantee type arrangement, and we are seeing their service costs decrease to us because it's net of their collection. So they are all credentialed, set up with their payers, billing, and that's going really well for them. So we anticipate that to continue to decrease.
And is that sort, oh, go ahead.
No, I did that ramp up on the schedule you anticipated it would.
Yeah, and I do not anticipate they will get to a full zero to where we don't subsidize anything. But so it'll be interesting to see how far down or how much they start collecting on their claims. But I wouldn't anticipate it going to where we are not subsidizing at all. But I don't know that exactly.
And are those numbers ever audited, or do they need to be audited?
We have full access to their reporting. Yep, we can request that. I get some standard boiler reports, and then we can request a full whatever we want. Yeah. Agency labor has all the departments have done really well working down agency labor through this year. So we are down $2 million in temp labor, and that's pretty much just nursing. There was some clinic labor, agency labor last year. The clinics aren't using any temporary labor. And then ICU, med surge, surgical services, they've been way down. The big one is still, the ER is still challenging, but they are getting more and more applicants and good applicants coming. So we've seen some significant changes in the market with agency staffing. And hope to see that continue. Keep looking at TV.
I know, where are you looking at? Ron and Dee Dee.
And just one more thing to touch on, like Michelle mentioned, we are working on presenting to the board an expand or a remodel of the orthopedics clinic that's currently vacated and the general surgery vascular clinic that will bring them up to provider-based spec and be a much more efficient place to provide care. So we'll anticipate seeing that in the next month or two. And that's what Michelle and Mitchell are working on, the grant funding to help support that. Any questions?
But seeing what? Like, what are you gonna pitch to us at that point?
A number.
Okay.
Floor plans, yeah. And estimated price of what would come with that, exam rooms, a full layout of what that will look like. Being with Bob and John on the first to go over it, the financial sustainability setting. And flush that out.
When do you think we'll be hearing from that as a board about the?
Best case scenario, February's board, but it'll be a little bit driven.
Probably the next time we're back in a profit.
Yeah.
I have a couple questions for you, Jason.
Yeah.
Just thinking, I know, were you ready to take questions or?
Yeah.
So first off, when I look at your investment sheet here for the year, it's like minus $811,000. Is that correct?
Yeah, so we have to go market to market. So they're bonds and they can depreciate what their value is. As long as we hold them to maturity, we get the full return on them. So in between cycles, they will show a loss, and then we have to hold them to maturity to have it back at.
Okay.
I customer that same question almost every month, because you hate to see those negative numbers, but it's an accounting requirement.
Yep,
And
so we do market to market to them every month. So if we were to liquidate one of them, so we can sell them at any time too. But if we sell them, we would realize that loss. So they're unrealized losses until we sell
Those
it.
ones with really low interest rates are not attractive, so you have to discount them for somebody to take them off your hands.
Yeah.
Okay,
So.
okay. The other question I have for you is more general, and I'm not sure that you have an answer for this, but I might have to do more with cost accounting. And do you have any idea how much it costs to onboard a new provider when they come in? I mean, is this I mean, my question is, you know, we have a lot of contracted people, we have a lot of local tenants, people here. But do you have any idea how much it costs us to continually be onboarding new providers? I mean, to me, it seems expensive on the surface, but have we done any analysis what that looks like?
I have years ago, and there was kind of a rule when I was doing that was like 1 to 2 times the salary. But I'd say the real is opportunity loss of revenue. So it's the cost plus the cost of lost opportunity is a significant one. So the training and.
So is it able to like forecast, okay, if someone only stays a year in our organization, I mean, would that be, you know, at what point is there a break even point? Like we really need someone to stay here for 3 years, you know what I mean? To kind of just break even with the cost that it takes to bring them on and get them up to speed.
Yeah, I used to say it was about a year. That's what I was kind of looking at by the time, and that's just looking at their ramp up on a productivity level. You'd see about a year, they would be kind of meeting what you would see as a typical average expectation. So it takes a long time to get them for a year, and sometimes more to get them up to speed. As you get into more specialty areas, it takes significantly longer. And the primary care, I'd say, is even shorter to that. Our demand is really high with primary care. If we start somebody now, they're full panel in 3 months. Is that answering your question?
I just wanted to say in sharing this information with my peers, they're, regardless of how we feel about this, they're all still pretty envious of where we're ending. It's tough out there. It'll be interesting. In 2022, the independent and smaller hospitals did well relative to the large systems. The large systems did not recover as much in 2022 as they had hoped, but I think the pain trickled down to the smaller hospitals more in this past year.
Okay.
A question, hey, what do we consider a full panel? How many patients is that?
That is something that gets kicked around in the literature. Currently for primary care, the number that's being used is about 1,200 or down as low as 1,000. And 20 years ago, it was 3,000.
Right, yeah, yeah. Thank you.
I think that varies too based on specialties.
Yes, and I don't have a good the best benchmark that we have for specialties is just looking at how many specialists there are per capita. But if you say that, if you acknowledge that the shortages are now across every specialty, then the number of specialists per capita is an underestimate.
I know when I left my practices, I think we sent out about 2,000 letters. Mature, but that was a mature.
And just the collections have been difficult the last, I'd say, 4 months. And it's like, even this week, it's just another layer of different the insurers are adding to getting collections. Molina was our gold star of Medicaid payer. They're now, as of this week, one of our worst this week. The amount of administrative burden that they apply to us.
Out of like denials or something, or what causes this?
Denials and audits and takebacks. They just say, oh, we overpaid you, and we take it off of another remit, and then we have to fight to get that back. And we typically will get that back. At least one we had successful this week. It was a $13,000 audit, and they said we disagree with how we paid it. We're going to take the whole thing back, not pay you some. And then we write a letter and they say, okay, give it back. So,
but one
amazingly
example
difficult.
on the audits, and this is the first time I've heard that, they are like, when they're auditing a chart, they'll no longer accept the radiologist report. They want the images. And it's over the top of what they're doing to avoid paying claims and to pay claims late. And it's just over the top. The idea that we have to send CDs with CT scans on it for an auditor to look at before they'll pay it.
And these are practices that I expect with the Medicare managed care. And Molina is a Medicaid managed care, and it looks like they just adopted Medicare managed care's practices. So it's just, yeah, it's one thing after another from that end.
Do they ever transition the other way from being orderly to being workshop?
If at least my experience, I had an experience with Premier and I just argued with them long enough and I just pushed back long enough, they finally moved on to the next, and now they're with Proster. So they literally
So
went from us to
pick on an organization
Proster,
and
they
you
went to the
won't
next
continue.
one.
Interesting.
Yeah.
We're feeling the
And
same
they-
thing, and, you know, denials for like stress testing and things like that. And, you know, we end up having to consult with a utilization team, what they call that, in order to get simple stress testing approved. And what they're hoping to become is a deterrent, you know, basically, you know, I'm so busy and seeing all these
Yeah.
patients and I don't have time to call them back. And that's a win-win situation. So you've got large insurers like United Healthcare, et cetera. I mean, and they're employing these utilization teams, to kind of be the middle person. And it, you know, you
They
can
know
get into
where-
some heated
And
arguments.
you've seen a change, like it didn't used to be this.
It's getting, yeah,
You
it's
can-
always been there,
yeah,
but it's getting harder.
You can feel it, yeah.
Yes.
Yeah, and not to pile on, but it's beginning to feel overwhelming.
Yeah.
It really is to the point of absurdity. And they used to at least like make up a reason why they were doing this. Now it's so they don't have to pay claims.
Yeah.
It's kind of their reason.
They contract with a third party always to do these, and those third parties are based on how much
Percentages.
recovery they
Yeah.
get. So they're in kind of a no loss position, and they just make you really rework for the funds that they've already paid to you.
Okay.
Yeah, like Dr. Hoppy said, it's exactly what they're still doing, and you can dig in someone like sleep studies. Just today looked into 5 of them. They paid 0.
And I know our case managers have actually had, you know, current patients that we're working on where we have to have our hospitalists actually talk with the insurance company. So then now we're having to arrange phone calls with, you know, a practicing physician and pulling him away from patient care to have these phone calls.
All right.
There's no system in place to stop these companies from doing that, it sounds like. There's no punishment for them making our lives extremely challenging.
So the audience for commercial plans in Washington State would be the Office of the Insurance Commissioner. And that is a great topic for Olympia next week.
Yeah.
To talk about these practices and stay away from conversations about rates and really just talk about these practices being overwhelming. And then on the Medicare front, HHS is, you know, our delegation to reach out to them and for them to put pressure on HHS to really stop these Medicare intermediaries and folks from behaving this way, so.
That's at the national level. With the Medicaids, it's the healthcare authorities. The healthcare authority has historically the last few years been in our ballpark and supported us. So we're back to engaging with the healthcare authority to try to get this managed care plan being reasonably. And you can see these, so a lot of what's driving our negative in the financials is this. So you can see our rate of collection has increased about 3%. 3% is $6 million. So it's huge.
So when you say rate of collection, that's from the insurance type companies,
Yeah.
not from the
Let's say, yeah.
All right.
Thank you. Well, then I have a,
Can I just say, because it's something John you've asked us to keep an eye on, you can see what happened to financial assistance year over year. Is up about $800,000 based on the new thresholds
Yeah.
the state legislature passed.
I feel like, again, word is going to continue to spread. People are going to start to understand again, not cheat the system, but as an individual, use it to their advantage with potentially high deductible plans and things like that. So it would be interesting.
On the couple more things, the investment schedule, I'm starting to go longer, or my practice is to go longer with some of those investments. Right now, we're able to get 3.5% to 4% on those, so you'll see those less maturing because I'm putting them out there 4 to 5 years, and I'm aligning them with our debt service payments that we'll have coming up. We have some balloon payments that we may want to refinance at a later time, but I'm also aligning our investments to mature with those payments. Then the last piece I wanted to touch on is just a resolution 24-01 for a property surplus.
Right.
surplus.
Before we get to that, are there any other questions about this report? Thanks. Bob, did you have something?
No.
Okay. All right. So sorry about that, Jason. So yeah, we have resolution 24-01. Getting rid of some chairs and vacuums, I guess.
Yep, chairs and vacuums. The chairs stem from the DOH audit or survey come in, and it's that some of these chairs have exposed wood from being cleaned so many times, and they were from 1999. So we got a lot of very good use out of those chairs. And then a casting saw out of the ER and vacuum that they're excited to get out of their storage area.
This stuff would be a surplus, and we're going to scrap all this stuff. Any questions for Jason about this before we entertain a motion? All right, so do we have a motion on resolution 24-01? Motion from Erica.
Second.
Second from Bob. Any further discussion? All those in favor of approving resolution 24-01 surplus personal property, please say aye.
Aye.
Okay, that's unanimous. Anything else, Jason?
That's all. Thank you.
Thank you very much. Appreciate it. Anything else before we move on from the reports and dashboards? All right, so education and board reports, just wish the Advocacy Day in Olympia is coming up next Tuesday. Dee Dee and I and John are going to be there to lobby. Terry's also going to be there in his capacity as on the governance committee with WISHA. So we'll be doing that. We'll report back following board meeting. Nothing under old business. New business. I just wanted to start a conversation with the board. Bob, I think that Mandy sent you something. But we've been talking a little bit about board compensation and travel. And so I thought we should start the conversation on this because we do have a policy on this. That we, it'd be good. We do have a policy on this, so I thought it would be good to kind of discuss this briefly. I'm giving you some numbers because I'm not sure how much we're aware of this stuff. And I don't expect you to absorb all this right now, but I just want to call out a couple of things. So there are three different components here as I see it. There's compensation for sort of meetings. There's insurance coverage, and there's travel to, for sort of development in it and board education. Okay. So let's start with compensation for meeting attendance. So we have a policy right here. This is the one that I distributed that says commissioner compensation. So there's a question about what counts as a meeting, right? So before I get to that, I will just sort of, this isn't our job. This is, we have jobs. I mean, some of us who aren't retired, but this is our public service, and so there is the option always of waiving compensation, and this is under RCW. The RCW that's included here in the packet says any commissioner may waive all or any portion of his or her compensation payable under the section as to any month or months during his or her term of office by a written waiver filed with the district. So that's always a possibility, is filing a waiver. Now that's I'm just saying that's an option because, I think we should have this conversation with the board, and we're not going to decide anything here. We can maybe come back to it at the next board meeting, but we do have to be good stewards of district resources. And that's not only sort of putting our boot to the neck of Jason and telling him to sort of squeeze as much out of the blood out of the stone as he can, but it's also, we have to sort of consider, our own expenses as board members. So let's just look at the commissioner compensation policy here. So this is what we consider under business of the district here. Attendance at meetings of the district. So regular and special meetings, that's this sort of thing. So meetings of committees and subcommittees, so finance, QI council, stuff like that. Meetings of board of directors of the foundation, educational meetings. So that would be, you could probably include Gembas in there, but also travel to conferences and things. The review of physician credentials, that really is out the window now because that doesn't, that happens online fairly quickly. I'm not sure that counts. We would want to count that as a meeting, but we could talk. And that's it, unless we approve anything else, right? So one of the things I'd like you guys to think about prior to the next meeting is what else we would like to vote in. Right? Because there's a bunch of stuff that that's done. We could stop the list here and say, for it to be a meeting, it has to be something where more than one board member is, and we have an agenda, right? So that's one way to go. Or we could expand it. But anyway, we need to revise the policy because it seems to me like as it stands now, perhaps all of us are not abiding by this. So I'd like to just clarify what we're doing. So think about this for the next meeting about what you think should be included as things we want to approve, or things you would propose to be approved by the board. Okay. So that's the first thing, that's compensation. The second thing is sort of insurance coverage, and that's the sort of big thing I'm doing. And I don't want to talk about specifics on that. I will just say, I'm not, this isn't about any particular board member or anything. This is just about getting us in line with whatever policy we want to have in place, and also to be transparent with ourselves really about what we're costing the district. And then finally is the travel and education. So as you can see, in previous years, like 2016, 13,000, bumped up to in 2017 to 22, and then down to 10. We're now at, we're budgeted for 2024 for $25,000 for travel and education. If we want to hold to our budget, then that would be 5,000 for each board member, which, doing a little poking around, talking to some people, you got to figure in state, it's about $1,500 total. And out of state, it's about $3,500. If you're thinking about registration, hotel, travel, flight, all this sort of stuff. So if we want to stick within our budget, that means that each board member could go to one out-of-state meeting a year this year, one in-state meeting this year. That would be Chelan or what have you. Now, I know that, Erica, you don't typically go out of state. So if we as a board wanted to sort of reallocate that money, we could do it. But I want us to sort of think about this as kind of a target, maybe, and not really a target, maybe it's a budget, sort of a guardrail. Hey, all right, that works for me. It's not, there's not unlimited money for us to just sort of travel to every educational opportunity that's out there. Now, the administration is not going to audit because, we're their, Julie's benevolent overlords. But, we got to kind of check ourselves a little bit, I think, and be a little careful and try to live within our means. So when you think about where you'd like to go to improve your sort of understanding of these issues. Just be mindful of what the budget is, be mindful of what it's been in previous years, and sort of think about how we as a board are gonna kind of stick to this. So we don't need to decide anything now. This is, at this point, it's just sort of informational about what the policy is, about what we need to do regarding the policy, if we want to expand what counts as a meeting, or if we don't. Think about, expenses in terms of insurance coverage, think about expenses for travel. I know that I know, for example, that people on the Board of Education, or the board for the local educational system, they all waive their fee for hospital meetings because they're pretty strapped. Now, we're not as strapped, but we do need to think about this seriously. I also know that a lot of other hospital commissioners, because maybe their places aren't so flush, are a little tighter on this. Anyway, I just think we need to reflect a little bit on what we're doing, make sure we live within our means, and and be very kind of intentional about what we're including, if we do want to include it on our sort of, right? So we'll come back to this next meeting so that we can get clear on our policy. Until then, just sort of consider these numbers in the privacy of your own home. We don't need to have any questions here unless you have any, but otherwise, I think we'll probably engage the policy more directly next meeting. Is there anything that anyone has to say now, or if not, I'll just move on. Good. Okay, so Erica had something that she wanted to sort of mention under new business.
Yeah, so I had the pleasure of meeting with a friend and associate, Stephanie Bowman. She's the area director for Habitat for Humanity. And I will admit, I did not know much about Habitat for Humanity, and I learned a great deal in the short time we had to meet together. They have a lot of services to offer the community, and one of the things is that one of her missions is to educate those who might be able to partake of the services, to be able to self-identify, to be able to navigate that system so that they can benefit. She's very eager to come present to us about what they have to offer. And I know that housing is always a pressing issue in this community. And so I would like to suggest that we invite Stephanie to present to the board about Habitat for Humanity.
And she has indicated she's available for February or March. So if you're open to either one of those.
People open to a presentation at, do we have any other presentations scheduled for February yet? We know?
Can't think of any.
Board self-evaluation will be starting.
Yeah, I don't think we need a presentation on that. So if she's available for February, I think that'd be good to see her. Is that good?
Great.
With you, Erica?
Absolutely.
She's also very interested in connecting with resources and making sure that our workforce understands that it's available for that.
I didn't mean to speak too soon. Are there any objections to that from the board members? I just
No.
assumed, but any problems? Okay, we'll put that on the February agenda then, please.
Thank you, everyone.
Thank you. Okay, we have just one thing to talk about in executive session. We'll take 15 minutes. So let's take a 6-minute break till 7:15, and then we'll reconvene into public session at 7:30. Sound good?
Yes, and the issue in exec is personnel.
Sorry, personnel, yes, under RCW 42.
No action anticipated, no action is anticipated, and I would ask that Mandy Olson stay behind.
All right, thank you.
Thank you, everyone.
Thank you.
Good night.
Oh. Thank you.
So Mandy, am I gonna